So just so you guys know that ARDS, or adult respiratory distress syndrome, is struggled a bit in being a very kind of heterogeneous group of conditions or group of pathologies, if you like. And so my first slide is really to just tell you that there's an attempt, and there has been an attempt, to try to get some consensus of what these things mean, and essentially try to define what essentially is a disease or disease process that affects everyone from neonates up until the elderly, but to try to define what makes it specific to pediatrics, in other words, when children get this kind of condition, and then to look at the evidence that you have, because obviously there's a massive amount of many more adults suffering than children, and so to try to see what evidence has got some good basis in adults and which we can sort of translate to pediatrics and try to make some recommendations. So those of you that have done a bit of ventilation, a bit of ICU before, will know what these things are. They're fairly straightforward. So as I said before, I mean, ARDS is one of those weird things before this that, you know, when you see it, you know what it is, but it was actually relatively hard to define. And so people set up different mechanisms to define it. And so what we kind of all go on is this Berlin definition, which was kind of about 10 years ago now. And to try to define what we mean when we say a patient has ARDS, although you'll hear it a lot at the bedside, but you know, to try to define that. So basically what is categorized is it's an acute diffuse inflammation. So you have a primary lung injury, which can be due to a whole variety of different things: infection, shock, you know, even blood transfusions, or a whole variety of different things, which essentially means that you have inflammation throughout the lung, which means that fluid builds up because of increased permeability, and it decreases the amount of effective lung tissue over which you can perform gas exchange. And so the follow-on from that is that obviously you get things like decreased lung compliance and increased dead space and kind of buzzwords that we talk about like that. But essentially what it means is that because the lung is so inflamed, it fills up with fluid, and the amount of lung tissue that's available for ventilation and oxygenation decreases. That makes sense. And so that's a kind of broad umbrella definition, if you like. And then, but it has to, I mean, there are, you know, some details which you need to talk about. One is kind of obviously has to be acute onset. So, you know, not something that's obviously been going on for months and months. And then normally, and you know, when I was a trainee, we always talk about full quadrant lung disease, but essentially means that you have on X-ray, you have opacities in all the lung fields. It's defined, I mean, very obviously by an impairment in the function of the lung, which we kind of can look at either as a deficiency in oxygenation or ventilation, but the definition is to do with hypoxia. In other words, you know, you can't, you can't absorb oxygen. And there are various ways, you know, to define that, and you'll hear a bit of terminology about that, and I'll talk a bit about what PF ratio means and FiO2 and all that sort of stuff. And then obviously the second thing is that it has to be a medical cause. I mean, so we would say not, you know, excluded a cardiac cause for this, because obviously, you know, pulmonary edema and lung infiltration things can be, you know, can have a cardiac cause. So that's the kind of that's the main structure of it. I mean, those of you that are anesthetic or have had ICM experience or pick and trainees and things will need to know about things like PF ratios and OIs and things like that. So, I mean, essentially what you need when you're looking at hypoxia is have some ratio which takes into account the amount of inspired oxygen that you give a patient and how much gets in the bloodstream. And how we measure the amount of oxygen in the bloodstream is by partial pressure of oxygen. And so the partial pressure of oxygen divided by the amount of oxygen you're giving is a PF ratio. there are kind of adjuncts to that, and you can use a saturation. There's something called the SF ratio. And in pediatrics, what we do is that we tend to use oxygenation index a lot more, which is OI, which basically is very similar to PF ratio. It incorporates the amount of ventilation that you're giving. In other words, what it's saying is that if you give an amount of oxygen, how much gets into the bloodstream for the amount of ventilation you're giving, and the way that you approximate the amount of ventilation you're giving is the mean airway pressure. And so you have an additional element to that, which allows you to factor in how much ventilation you're actually giving. And there's many things. You can pick your beast, or you can pick your method of description. But in pediatrics, when you're talking to other pediatricians, when you're talking to other intensive care doctors, OI is the thing that the main thing that we talk about. So, for example, if you were to be involved with a child who required transfer to a ECMO center, for example, for ARDS, the first thing they'd ask you is what the OI is. Yes. Does that make sense? And so, but the definitions, the Berlin definitions of ARDS are not based on OI; they're based on PF ratios. And so, essentially, what again, I'm going to try to decode the terminology for essentially what it means is that if you set a standard PEEP, in other words, more than 5, if the ratio of the oxygen in the blood divided by what you're actually giving, in other words, how much actually is getting to the bloodstream, that defines how severe that ARDS is. I mean, it's fairly straightforward, right? So if they've set kind of, boundaries for which, you can define the level of hypoxia, and secondly, the ARDS severity, but pretty much it's based on the ability to to get oxygen into the bloodstream. Obviously, this is not a direct measure of lung injury. That's a very difficult thing to do. And so these are all approximations for what that might be. And if you look at ARDS, it's very well known to have different phases. And this is something that is very evident both at the bedside and also kind of in the science. So you have your triggering agent, whether it's sepsis, pneumonia, shock, trauma, blood transfusion, the things I talked about. And essentially what happens is that there's an immune cascade that goes off, and you get it, and then the whole cascade of lung injury. And immediately, it's, because as we said before, it's defined by its generalization that always affects the whole lung. And so you have this diffuse alveolar damage. And so you have an acute phase, which is the first week, in which you get lots of edema, lots of neutrophils coming in, cytokine production. It's a very immune based. And then you have another phase, which is the proliferative phase. I'll just move this over. Which essentially what happens is you get fibroblast proliferation, and then you start to get fibrosis. Sorry. And then you go into a kind of a fibrotic phase, which is kind of, I guess, the body's trying to heal. And so you get lung fibrosis and also alveolar structure, and and things like emphysema and things like that. And you can see by the phases in that little graph, they'd say that different mechanisms are in play at different times through the condition. So edema is kind of very prevalent in the beginning, and then inflammation, and then that kind of is taken over by fibrosis, and then hopefully resolution. But it's the timing of the processes are different. And again, this is not the sort of thing you have to remember, but this is just a kind of sorry, is this a demonstration of all the process going on, so that everything from sloughing of the epithelium, neutrophil infiltration, cytokine release, fibrin deposition, and proteases going crazy. You break down the hyaline membrane. All those processes are going on acutely in the lung, which basically are producing the inflammation that we're seeing, and then the after effects of that later on. So obviously that, when you have a child in the intensive care unit, the most obvious and florid thing will be not only the degree of hypoxia, but also kind of obviously the X-ray change. So classically, you see 4-quadrant infiltrates, edema due to, vascular permeability, and then they kind of developed into kind of this kind of ground glass, widespread, small airway pattern. It's a very characteristic of ARDS. And this kind of, the small airway pathology produces this, what used to be called ground glass, now it's called reticular pattern of disease. But I mean, classically, the hallmark of it is that this should be affecting the whole lung, because as I explained to you before, it's a diffuse immune process that's going on. And in terms of the broad strategies that we use, and this is just a kind of, sorry, it's a busy slide, but there's a lot of interventions that potentially we will start to do. But the first thing obviously is initiation of mechanical ventilation. And obviously that allows adequate, hopefully in the beginning at least, of management of oxygenation and ventilation. And you obviously understand the difference. Oxygenation is getting oxygen, ventilation is getting CO2 out. And I mean, I won't describe all the studies, but essentially what we're practicing is that what is called an open lung strategy. In other words, we're trying to open the lung to minimize tidal volume, to maintain PEEP, limit the amount of pressure that we have to give, and then obviously then using invasive ventilation, using sedation, using muscle relaxant, all those kind of things to make sure the lung essentially stays open. So what this describes is essentially a stepwise escalation of treatment that we commonly use in the treatment of ARDS. So the first one really is mechanical ventilation. And this is why that you'll see at the bedside, we try to limit the tidal volume 6 to 8 mils per kilo. And the thing that allows us to do that is to allow permissive hypercapnia. So pH above 7, 7.25 is okay for us. And that allows us, permissive hypercapnia allows us to limit the amount of what used to be thought of as barotrauma. Now we think more of volume trauma. In other words, expansion of the lung causing shearing of the lung, of the already inflamed lung, to allow us to manage them on lower tidal volumes. And so you also on the ventilator, low tidal volume. The plateau pressure, those of you that watched intensive care before will know what that means. But I mean, if you don't know what that means, essentially that means what we try to do on the ventilator is try to equalize the pressure between the ventilation and the alveolus. And essentially what that tells us is that's the static pressure all the way through the airway. And we try to limit that to less than 30 if we can. Obviously, some conditions don't allow us to do that, but essentially we try to limit the pressure as much as we can. We try to maintain their open lung by giving PEEP. And so you'll find children, particularly, I must say when I started, we used to use lower PEEPs than we use now. We're quite comfortable using PEEPs of 8 to 10 and 12, but that allows us to keep the lung open. There's a direct relationship, obviously, between PEEP and oxygenation. And I'm not going to go into the science too much of that at the moment, but if you wanted to, then we can at a later date. And there are also some other adjuncts that we try to use. And so we try to use neuromuscular blockers if we need to. You can use prone positioning if you want to as well. And if all else fails, then they have to go for something called VV ECMO, which essentially is respiratory ECMO. There are some other adjuncts that we use in pediatrics quite a lot, and one of them is high frequency oscillation. There's good evidence now that in adults it makes no difference. Actually, it might make you worse. But in pediatrics, still occasionally we use high frequency. And the other thing that we use that you'll be aware of is nitric oxide. Nitric oxide is a very potent pulmonary vasodilator, decreasing our pulmonary pressure and which allows increased pulmonary blood flow, which allows gas exchange by increasing blood flow into them. There's other mechanisms as well as smooth muscle relaxation and things like that, but essentially it's an issue of blood flow. So that's a little summary slide, and then I'll go into a bit more detail about what those things mean. So again, it's not important necessarily in our first session really to talk too much about the evidence for things and the recommendations of consensus meetings and stuff. But essentially, this important points to remember are low tidal volumes and low inspiratory pressures if you can. In other words, as little as you can get away with. There's excellent evidence, where from animal studies all the way through to randomized controlled trials looking at low volume ventilation. And so what we try to do is limit the tidal volumes. Prone positioning is an interesting one because up until relatively recently, proning wasn't part of routine care in children. And certainly there's a variety of different reasons why it's become more prevalent. And essentially a combination of good studies, and those of you will know, there's now good evidence that proning is a benefit. But also kind of, I think after COVID, a lot of people have just become a lot more familiar with proning. And so proning has become a much larger player in the way that we manage kids with ARDS and with ARDS. High frequency, as I said, in adult practice almost disappeared completely, but we still use high frequency. High PEEP. And one of the things that, again, recruitment maneuvers are essentially physical acts that you can perform to try to recruit the lung. As you know, there's this thing called lung hysteresis, which is another subject in itself, but essentially the lung performs very differently if it's recruited or whether it's de-recruited. And so what you try to do is to do certain maneuvers that might help to recruit the lungs. And ultimately, none of that stuff works as ECMO, which essentially is extracorporeal, in other words, which means going outside the body, the blood is oxygenated, CO2 is removed, and it's given back to the patient. And what that allows the lungs to heal, not relying on the lungs for ventilation oxygenation, and that allows the lungs to recover. But the practice of doing lung productive ventilation does mean that, so practically what we're doing is that we're allowing the pH to be lower than physiologically normal. We're allowing the CO2 to be higher than normal, and we're allowing the saturations to be lower than physiological as well. So we would normally target 88 to 92, in some cases even lower than that. And again, there's a recent very good pediatric study which shows there's no harm in lower saturation targets. We decrease the amount of stress the lungs under by giving less pressure. We minimize collapse by making sure the PEEP's okay. And also one thing I haven't talked about is ventilator synchrony. So in other words, getting them to coordinate with the ventilator, which essentially means in a very sick patient, muscle relaxing them. But when they're improving and when they're breathing spontaneously, try to get them onto spontaneous modes. In other words, when they trigger themselves. What you also try to do a little bit is try to prevent things that can make it worse. It's one thing trying to make things better, but also you're trying to prevent things that make things worse. And so one of those things is VAP, which is a ventilator-associated pneumonia. So most units will have a whole strategy, and we certainly have a VAP bundle, which essentially means that you do certain things which help to prevent infection. In other words, how you nurse the patient, and kind of having criteria by which you give antibiotics and that sort of stuff, and physiotherapy and things like that. But the thing is about PEDS is that there's not a lot of evidence for a lot of the things we do. Like I said, the studies are relatively small. The amount of children that develop ARDS is also small. But also the thing is, to remember that anywhere from 1 month to 16-year-old, this very heterogeneous population. It's quite difficult to make recommendations about those sort of things. But so I'm not going to talk too much about this stuff. But essentially, what I want to do is I want to give you a little insight just into the things that we can do to try to help ARDS. So we talked a little bit already about the ventilation strategies, but there's other kind of things we can do as well, which will help. And one of them is sedation. So most patients with ARDS obviously have to be well sedated, and at the moment we do with morphine and midazolam, and you know, and at the moment in pediatrics, that's probably the best combination that we have. I know, you know, you've seen other drugs that are used, clonidine and dexmedetomidine and that sort of stuff. But I mean, essentially, what you're trying to do is decrease ventilator asynchrony and also decrease metabolic demand and things, and the usual kind of ways that we do to help the lungs to work. But you know, almost all of these patients will be on muscle relaxant, and normally we do that in the acute phase, and as they recover, hopefully we can stop that. But we do often use windows, and that window basically essentially means that you stop the muscle relaxant if allowable. In other words, the clinical condition allows it. For now, and when we see movement, then we can restart it. At least it shows that you're able to come off it quickly, and also there's no neurological deficit afterwards. It's also important to make sure that the patients are well nourished. In other words, we start the feeds almost immediately and make sure that we take into account the energy expenditure and make sure that they're not in a calorie deficit and not in a catabolic state. The other thing is that maintenance of hemoglobin. So as you know, in intensive care units, there's no value in having hemoglobin at a higher level than is physiological, and we tend to not to transfuse until they're down below 7. There are particular cases where oxygenation is very difficult that I know that people have previously, and there's some thought whether you can increase oxygen delivery by optimizing hemoglobin. But if you have a good cardiac output, actually, you know, having a hemoglobin high doesn't make any difference really. You know, that's really more to do if you have a low cardiac output state, for example. So we normally don't transfuse unless it's below 70. So in general, in pediatrics, I mean, I think that there aren't any kind of, you know, golden nuggets that we do particularly different. I mean, there's no consensus about what the best strategy is, except low volume ventilation. Fluid balance, actually, the one bit I didn't speak about is fluid balance. So it is in again, you know, in adult practice, there's, you know, very good studies which show that the detrimental effect of fluid overload is, but you know, you have to remember that in an adult, you know, people can be, you know, 20, 30 liters positive. I mean, obviously we don't often deal with the positivity of that extreme, but in general, we like to keep children in a negative fluid balance. And we like to make sure that they have, I mean, you've seen already, they have a, what's the word I'm looking for? We have inline suction. So essentially what it means is that you don't disconnect the children too often from the ventilator. There's a whole variety of reasons why that's important, to do with recruitment and also kind of secretion management and the amount of sedation you have to use and all that sort of stuff. But there's no consensus about the right thing to do. There's a whole lot of other treatments. I mean, you'll see that, I mean, I don't know whether either of you here when Evie was on in the middle of our ARDS episode, but the question of steroids always comes up in ARDS. And there are kind of two schools of thought, really. One that says that, you know, steroids may have an effect, but they have to be given at the right time. And if you give them too late, you might miss the boat. But there's another school of thought that actually says that, you know, steroids are steroids, and you know, we should be using them if we're stuck. And so, you know, a very small subset of patients will get methylprednisolone to try to wean them off the ventilator, but that normally comes a bit later on in their clinical course. Again, I mean, in your reading, you may have seen other treatments and drugs that we sometimes use, prostaglandins, Heliox, you know, DNAs and all this sort of stuff. There's no real kind of, you know, there's no consensus about those being useful treatments. Okay. Yes, that's more about. So I was just going to finish off with one little thing about proning. So proning was one of those things that there wasn't a lot of evidence for, and we weren't that keen to prone children that often. But there was a study called the Perceiver study, which, you know, some of you will have heard about in the New England Journal of Medicine, which essentially said that, I mean, I won't go through the data with you guys now, but in severe ARDS, if you prone them early, you certainly can have an effect on outcome. And so we that, I think, in a combination of post-COVID practice, we have started proning children more. But as you can imagine, with big children, as there are with adults, it takes a lot of people to do it. And it does come with risks, pressure sores and things like that. And obviously, the turning process, they can lose their lines, things like that. But I mean, essentially, we're using a lot more than we used to. And I'll just say one line also about ECMO. So essentially, what you're doing with ECMO is that you're kind of taking the blood volume, normally from the arterial side. But the thing is, with respiratory ECMO, you haven't got a pump problem, so your heart is still working okay. So that's called VV ECMO, and that's normally on the respiratory side. So you can actually cannulate just veins to do that, and actually you can just cannulate a big vessel, like the IVC or something. But it's often there's two cannulas put into the venous system to be able to provide membrane oxygenation and CO2 removal. Sorry, my throat's slightly dry. So I was going to say two words about that, and just because I was going to the last time, but I started giving this talk in the middle of COVID, and so I used to have a bit of COVID, but it's probably less relevant than it was. The vast majority of our children who have ARDS will be triggered by infection, and so every winter, particularly, there'll be a subset of patients with paraflu or flu or RSV who will go into what we call ARDS, and so they initially start off as being a single organ problem, and then normally develops onto severe hypoxia, 4-quadrant X-ray changes, pulmonary edema, challenging ventilation, all that sort of stuff. So, as I said before, is that it's very unusual for there's a smaller subset of patients which have that presentation almost when they start, but it often develops over a few days. And so you can see that there are certain things that we're doing which are kind of preemptive. But when they do develop full-blown ARDS, we have to kind of, a little bit like neuroprotection, in that you have a whole catalogue of strategies that you use to try to decrease brain metabolism and try to decrease the work the brain has to do. You're essentially doing the same thing in the lung, and you're using this, a different set of criteria, but criteria all the same to say, well, have I done this? Have I done this? So this is not a bad aid memoir to make me think, well, have I made sure the tidal volume's limited? Have I made sure that PEEP's adequate? Have I made sure that I'm not giving too much oxygen, and I'm doing that by decreasing the saturation limits? I'm making sure there's adequate sedation, adequate neuromuscular blockade, and also making sure that they're not in too positive a fluid balance. So, you'll see that every day. With kind of with patients who are in respiratory failure, and so part of what we're doing is trying to preventive, but actually we're trying to treat it with these kind of strategies. So as you guys work in the winter, you'll see this quite a lot. So it's useful to have an idea about, one, the expectation of what we all would be requiring, but also why we're doing what we're doing. Does that all make sense? The additional thing also, as I said before, you may see children on nitric oxide during the winter time. It tends to be reserved for the neonatal group because they tend to have pulmonary hypertension just from having chronic lung disease. But if we're struggling with oxidation, we'll use it in children of any age.